Now see, the competency based, you will be having the schedule for each class. Abhijit sir is posting what will be taught by which teacher and also the competency number. It might be histology, it might be your gross anatomy or anything. So you just, and also you follow your book. And one thing is that, how many of you have registered with Marrow, online Marrow? Amongst you, you have, stop it. Stop it. You have spent 8,000 rupees, stop it. Because I'm telling you, there is no shortcut. It is Marrow is a online, whatever you call it, is for the postgraduate. There is a question of anatomy, physiology and biochemistry. So Marrow is who has passed the MBBS course, go for postgraduate, NEET, PG, then you can study, just sweep over, you're having a knowledge, foundation, everything. This is to be noted. But you have your book, whatever you have purchased, whatever you don't change. Bisram Singh, Indrabir Singh, A.K. Datta, whoever the persons are. They are beautiful books. You just have a book, you have your atlas if you want to. If you don't have an atlas, have a notebook, big khata. And just you copy paste. You understand why I'm saying copy paste? You go through reading and then you go drawing and label it. As you go line by line, label it. The practicals which will be taught, say lungs, heart, will be demonstrated to you. You, after seeing the tissue specimen, the teacher shows you that what are the how a right lung looks, what is the left lung, what is the heart. Now you just have to put, in that time you see, only see, observe. And once you have finished, your 10 friends go to collect there, have your book there, and you go on just seeing it in a tab or this thing. Phone hobe na. But phones are good, but don't depend on it, because your Sudarshan chakra of Geo will go. That means you are having Wi-Fi not connected. You get disgusted, you put your things in and you walk out. Don't walk out. 15 minutes it will take you to the canteen. So you just have your bag, put it there, wash up in the canteen, and then you have your lunch, get a 15 minutes rest or nap for the next class. You follow this routine for the coming 8 months, you will walk through the exam. And always study with your roommate, or four of you collect in one room. One day in his room, one day in his room, one day in his room. 4 or 5 gathering. 4 people will be just okay. And staying outside, you having the luxurious life flat you have taken outside the medical college hostel. It is your personal decision. But I would say, from my experience, stay in the hostel for the coming 8 months. Kichu holo, ratri 10টার সময় you have a problem, you go to, hey, Sandeep, knock. Sandeep, I can't understand this portion of biochemistry. আর ও তো সময় নষ্ট করিস না, এই ফার্স্ট ডেস্কে বস, আমি দেখতে পাচ্ছি না, এত লোক আছে যে দেখতে পাচ্ছি না। You, I'm telling you at this level, actually you have come from the school direct to the medical college. You are having 8 months or less than 9 months. So you just gear up for the marathon. See, it is the difference between a 100 meters race and a marathon. Marathon, you just walk, just you jog like at the same speed. So your result you will get. And there is no, like Marrow's anatomy, I have not seen. I have to sit with you and see one day in the practical room, online, whatever it is. But this is for postgraduate. What Marrow is showing you, or they are having online classes, Abhijit sir, Subramanian sir, they are showing you. Myself, we try to demonstrate, but each have their own way of teaching. And don't bunk class. I told you earlier, now these 7 months, please don't bunk class. I'm saying please. Our teachers never used to request us to come to class or something like that. আমরা পড়ে থাকতাম, মানে ডিসেকশন পিরিয়ড ছিল 2 ঘন্টা, তো ডিসেকশন করতে করতে তোমার লোডশেডিং হয়ে গেল, তাও স্যার ডক্টর প্রফেসর হরিদাস ব্যানার্জি is okay, let it be load shedding, you just talk amongst yourself. You see, I had the opportunity to have the best teachers in Bengal, and also when I did my MS, and I'm telling you, through your consistency and everyday timing. Okay, now see, mention blood supply, lymphatic drainage and nerve supply of pleura, extent of pleura, and describe pleural recesses and their applied anatomy. Now lungs included in serous sac, pleural cavity. Pleura, delicate serous membrane lines pleural cavity, 2 layers. Inner visceral pleura covers lungs and outer parietal pleura lines the thorax. See, this is the blue lining and this is the pink lining. The roots of the lung is here. Now thoracic vertebra is the parietal pleura, this is the thorax, and this is the mediastinum, and this is the sternum. Now this is a transverse section through the thorax. Now see, you go to this thing, your hostel, you take a pillow cover and put your hand like this. Then it will give you a covering. So there will be the parietal layer and this is your visceral layer. Now both the pleura continues with each other at the hilum of the lung and along with pulmonary ligament. This is the root. Now visceral pleura covers outer parietal layer lines the thoracic wall and mediastinum. Now when you see in the dead body, you will see the covering. When you see the specimen out, then you will see your visceral pleura. Okay, this is one thing, you just basics you have to know. Now see, this is again a repetition. During embryonic life, fetus has 2 pleural sacs, initially called pericardioperitoneal canals. See, this is the laryngotracheal tube, this is the pleural sac, this is the lung bud. Now the trachea, the lung, even imaginating the lung bud here, and parietal pleura and visceral pleura. See, now see, this is the thing I was telling. So it becomes clear. Now the trachea, in green the visceral pleura, in blue that's the parietal pleura. Lung or any organ in the abdomen is covered by the serous layer, that is the, in the abdomen, the peritoneum, and this is the your pleural sac. Now, the layer of pleural sac covering lung forms visceral pleura, whereas the outer layer forms parietal pleura. Now, embryological aspects of pleural cavities: thin persistent space between two layers of pleura from pleural cavity. Surface of pleura facing pleural cavity lined by mesothelium, simple squamous cell epithelium. Pleural cavity contains serous fluid, pleural fluid that helps in lubrication. Now, what is the function of the your lung? Naturally, it's an organ of respiration. So so that has to glide and that has to move, and also it has to blow. Then it cannot be rigid, and the bony cage is there with the intercostal muscles. Now the things it expands, your lung expands, the pleural sac. Now pleural sac. Now, if there is any inflammatory condition, then there will be some excess of fluid, the serous fluid collecting in your thoracic cavity. That I will come to. Now, you can see, now this is the repetition. This is the repetition here. Now, layer of pleura. Pleura consists of two layers: inner visceral pleura, outer parietal pleura. Okay. Now you can see the skeleton and the when I taught you ribs and sternum, then you see these intercostal spaces are there. Okay. Now this is the diaphragmatic pleura. This is the diaphragmatic pleura. That is the costal pleura. This is the costal pleura in green. And left principal bronchus, this is the aorta, and this is cervical pleura, this is cervical pleura, the apex. Now this is the pericardium, this is diaphragmatic pleura, and diaphragm, this is the diaphragm. Difference between parietal and visceral pleura. Question: list differences between visceral and parietal pleura. Visceral or pulmonary pleura, inner layer of pleura covers surface and fissures of the lungs thinner than parietal pleura. The parietal pleura is thick, but you see in the lungs, few of you have seen today, the rest you'll see, and you will see it is just a thin layer, and the fissures, it goes inside and again reflects. It is the right side, there are 3 lobes, and the left side, there is 2 lobes. Now, cover surfaces and fissures of lung thinner than parietal pleura, derived from planktopleuric layer of lateral plate. This is embryological. Layer of lateral plate to exudum, blood supply and nerve supply from bronchial vessels, and nerve supply from autonomic nerve, sympathetic from T2 to T5 nerves, parasympathetic vagus nerve. Pain insensitive. Pain is not there, insensitive. Now, parietal pleura the outer layer of pleura lines thoracic wall and mediastinum, thicker than visceral pleura, derived from somatopleuric layer of the lateral plate mesoderm. Blood supply and nerve supply from body wall, nerve supply, somatic nerves, intercostal and phrenic nerves, pain sensitive. So, if there is any pleurisy or any injury, your parietal pleura is pain sensitive. Okay? Now it's supplied by the nerve supplied by the somatic nerves and intercostal. Now these two guys can come as a 4 marks question. These your parietal pleura, the differences between parietal and visceral pleura, list differences between visceral and parietal pleura. This will be a short question of 4 marks. Now you can see the costal pleura. See the costal pleura. This is cervical pleura. This is the mediastinal pleura, and this is diaphragmatic pleura. Now this is your parts of the parietal pleura, right. Now again your list of parietal pleura. Write short notes on parietal pleura, parts, blood supply, nerve supply, clinical importance that I told you. Now thicker than visceral pleura, has 4 parts subdivision: costovertebral pleura, diaphragmatic pleura, mediastinal pleura, cervical pleura. It is the area that is being covered. So the pyramid, the lungs is a pyramidal structure. Now if you imagine, you see it in the dead body and your specimen also book. It is has 4 parts. Costovertebral pleura means the rib cage of the thorax. Now from vertebra to the rib is the costa that goes. That is line and comes anteriorly in the mediastinal. Okay? And cervical, the apex part is the cervical pleura. Now parietal pleura, costovertebral pleura, previous name costal pleura, lines the inner surface of thoracic wall, separated from the thoracic wall by endothoracic fascia. Diaphragmatic pleura, firmly adherent, superior surface of the diaphragm. When you see the specimen of the diaphragm, you will see it is adherent. Okay. Now continues on sides with costovertebral pleura and medially with mediastinal pleura. The cervical pleura, cupula. This is also called cupula. Cervical pleura, dome-shaped part of the pleura, covers apex of the lung, extends into the root of the neck, 5 centimeters above the first costal cartilage. Okay. Now covered superiorly by suprapleural membrane. It is covered by the suprapleural membrane. Now cervical pleura or cupula relations: anterior subclavian artery, inner border of first rib, scalenus anterior muscle. The anterior relation is the subclavian artery, inner border of the first rib and scalenus anterior muscle. Posterior neck of the first rib, lateral inner border of the first rib, scalenus medius muscle in this place, this part. And medial major vessels of the neck, superior suprapleural membrane and supraclavicular part of brachial plexus. Now inferior apex of the lung. Now parietal pleura or mediastinal pleura covers medial surface of the lung from lateral boundary to the mediastinum. Okay. Now you see the cervical pleura, costal pleura, costovertebral, mediastinal pleura, and this is diaphragmatic pleura. Continues with pulmonary visceral pleura along the hilum and lung and pulmonary ligament. You see the specimen, see your text, and you compare. and immediately draw a rough sketch. Now, the pulmonary ligament, write short note on pulmonary ligament. This can be a short note. Okay? Now, see, this is the right principal bronchus, right pulmonary vein, and arterial bronchus, superior pulmonary artery, inferior pulmonary artery. The root of the lung, you see in your textbook, there's a nice picture. Over there, the relations of the thing, your hilum and your pulmonary ligament. This is the pulmonary ligament. It covers all this and comes as a tail. Like your hoodie. You have put on a hoodie, that is a covering, and from there, the bronchus and all this you see in the medial is going into the lung. Two lungs are like this. Okay. And now, as the hoodie comes up to the thing, that it is the pulmonary ligament. Over there, he is wearing a hoodie, he is wearing a hoodie. So you see, imagine that this is, okay, the lower portion of the thing is the pulmonary ligament. বোঝা গেল? বেশ, এবার কথা হচ্ছে what this is the lung, the parietal pleura, visceral pleura, pulmonary ligament, pleural cavity. This is pleural cavity. Now, space of pulmonary ligament is filled with loose areolar tissue, few lymphatic, sometimes accessory bronchial artery. Relation, medial, the esophagus, lateral mediastinal surface of the lung, and superior hilus of the lung. This is the hilus of the lung, inferior ends in a free sickle-shaped contour. Now, pulmonary ligament potential space. Pulmonary ligament provides potential dead space for expansion of the pulmonary veins. These are pulmonary veins here. Permit descent of root of lung. During inspiration, and pulmonary ligament provides space for the descent of the root of the lung. Descent of the diaphragm pulls lung downwards. Descent of the lung, the diaphragm pulls. Naturally, this whole thing, it descends, the ligament provides space. It has to have a space. If it is like this, then the lung cannot expand. Okay? Now, this is the root of the lung. The structures in the root of the lung. Epipartial bronchus, right pulmonary vein, then hyperarterial bronchus, here, superior pulmonary artery, so inferior pulmonary artery, pulmonary ligament. Now, this is a repetition of the picture. Now, surface markings of pleura. Anterior margin, also called Costomediastinal line of pleura. Okay. And pleural reflection can be marked as follows. Extends vertically downwards from right sternoclavicular joint, the right sternoclavicular joints, and your midpoint of sternal angle, Now, further extends up to midpoint of zipisternal joint. Okay? Now, this is the posterior aspect. Now, you see it is best is that you do a surface marking on your friend's body, or your friend does a surface marking on the thing with a chalk powder. Use the points. Okay, your body is your anatomy, and you study with your colleague or your friend. Okay. Now anterior margin on left extend downwards from left sternoclavicular joint, midpoint of the sternal angle, further descend vertically up to level of fourth costal cartilage, T1. Then arches towards the left, reach the left margin of the sternum, further descend downwards, reach sixth costal cartilage, E1. Deviation is due to location of the heart, bare area of the heart. You see, when you see the specimen, it will be more clear. Okay, location of the heart, bare area. Now, recesses of the pleura. Now, recesses of the pleura, see, costodiaphragmatic recess, this. Costomediastinal recess, this. And this is the pleura. The costal cartilage, rib. Now, pleura is here, lung, this is the lung. Now, along pleural reflections, pleural recesses or pleural line gutters are present. Now, if there is a reflection, there is a reflection in this part. It goes and reflects. Now, there are in the over here in the your this costodiaphragmatic recess. When you give in and see, there are 3-4 places you will be asked question. One is in the OSP, surface marking, and also your X-ray plate, radiographic plate. There will be an arrow in the costodiaphragmatic recess. You have to write costodiaphragmatic recess. Then what is the importance of costodiaphragmatic recess? If there is any pleurisy, any inflammation of the lung, or there is a pneumothorax, or just simple any infection, pyothorax, these. Now you have to take in the mid clavicular line and the thing, and then you over here and over here along this portion of the lateral wall, and your point is in the your over here. Now this is covered by fluid. Due to pleurisy, due to any inflammation, there will be tuberculosis or some tuberculosis having a pain also. But if there is any pathological condition or some injury or something like that, now over here you have to do a tap. The costodiaphragmatic recess is what color you send it might be serous collection, but you send it to the pathology, microbiology, and also your this thing that you see in your when you tap in a syringe, then you will see the color. You give a note, blood note if it is hemothorax, and if it is pneumothorax, if there is injury, there is air in the pleural cavity, the lung collapses. Even there is a mediastinal shift. Okay. Now, recesses of the pleura. Write short notes on recesses of pleura. Egulo questions. Question ache thoracic. Thoracic question. Okay. Now, definition. Potential reserve space of pleural cavity lies between parietal and visceral layer. Pleura. Narrow space between parietal and visceral pleura except along the diaphragmatic and mediastinal reflections. Now, in the diaphragmatic, the lining, it is adherent, and in the your along pleural reflection, pleural recesses or pleural line gutters, and function potential phase of lung expansion. Okay. Now, recesses of the pleura, write short notes on recesses of the pleura. Number of pleural recesses. Number of pleural recesses. Now, two major pleural recesses inside costodiaphragmatic recess and costomediastinal recess. Now, two minor recesses, retroesophageal recess, right and left, and infracardiac recess. The location of the heart and the location of the esophagus, there is a potential space. Your two minor recesses, retroesophageal recess, right and left, and over here two major pleural recesses, costodiaphragmatic recess or costomediastinal recess, intracardiac recess. Now, costomediastinal and costodiaphragmatic recesses are, see, this is the recess, costodiaphragmatic recess, and costomediastinal. This is the pleura. Now, pleural recesses is short. This is a flow chart. Potential phases of pleural cavity. Costodiaphragmatic recess lies inferiorly, lies between costal and diaphragmatic pleura, larger and most dependent recesses. Costomediastinal recesses lies anteriorly, lies between costal and mediastinal pleura. Left recess is larger than right due to cardiac notch in the left lung. When you see the lungs in the dead body or the specimen itself, you see the lung, it face the two lobes. The face for the heart, the lingula of the lung. Now that is taking space. So clinical integration provides spaces for lung expansion during deep breathing. Clinical integration in pleural effusion, fluid accumulates in the costodiaphragmatic recess, and radiograph obturates the costodiaphragmatic angle. So, now in this, if there is fluid collection like this, so this portion there is a fluid collection. You will see in the radiograph. The radiograph, when you see the plate, you will see if there is a fluid collection on the right costophrenic recess. Then the examiner will ask you, or when you are doing, the examiner won't ask you because you are having direct, you have to answer the question, seeing the plate. So these recesses will, nature is protecting, or nature's, your action is this, such. Now, now what is the radiograph obtains the costodiaphragmatic angle. Now, costodiaphragmatic angle, what is costodiaphragmatic angle? Your diaphragm and the rib cage. Now, if there is a fluid collection, then you have to collect the fluid. It can be your pneumothorax, so if there is an injury or contusion of the lung. over here, and then you tap. Now mid-axillary line location extends from 6th to 8th rib in the mid-clavicular line. I told you earlier that mid-clavicular line in the location is 6th to 8th rib mid-clavicular line. 1 to the 6 to 8, then 6 to 8th rib in mid-clavicular line, 8th and 10th rib in mid-axillary line, 8th and 10th rib mid-axillary line, 10th and 12th rib in paravertebral line, the costodiaphragmatic recess. But you can access through the 6th, 8th rib in mid-clavicular line. Best position is the mid-axillary line, near 5 centimeters in the mid-axillary line. Mid-axillary line, not in this. From the dependent lowest part of the pleural cavity, fluids in pleural cavity, pleural effusion tends to accumulate in this recess. Okay. Now you see the coronal section and the your transverse section. You can see 8th rib, see 8th rib, and this is the intercostal vessels and nerve, vein, artery, nerve. Now intercostal muscles are there. 9th rib is here. Endothoracic space is here. Fascia, this is the endothoracic fascia, and 10th rib. Costomediastinal recess. Small space lies anteriorly behind the sternum and costal cartilages. Okay. Between costal and mediastinal pleura, right costomediastinal recess normally occupied by anterior margin of the right lung, even in quiet breathing. Left costomediastinal recess larger, less occupied than right due to presence of the cardiac notch of the left lung. Some interesting facts are the intrapleural pressure always negative, -4 millimeters of mercury. Retroesophageal recess, right and left, lies posteriorly between costovertebral pleura and mediastinal pleura, lies behind the esophagus. Intracardiac recess only on right side, extends behind inferior vena cava. Normally, pleural cavity contains 5 to 10 ml serous fluid, normal. Now, in intracardiac recess, only on the right side. Infracardiac, that means it will be on the right side. And extends behind inferior vena cava, normally pleural cavity. Nerve supply of pleura. Now, parietal pleura develops from somatopleuric layers of lateral plate mesoderm supplied by somatic nerves, pain sensitive. Intercostal nerves supply costal and peripheral part of diaphragmatic pleura. Phrenic nerve C3, C5 supply mediastinal and central part of the diaphragmatic pleura. Now, this is supplied by somatic nerves, pain sensitive. This is important. The parietal pleura develops from somatopleuric layer of lateral plate mesoderm supplied by somatic nerves, pain sensitive. Intercostal nerves supply costal and peripheral part of the diaphragmatic pleura. Phrenic nerves C3, C5 supply mediastinal and central part of the diaphragmatic pleura. Now, visceral pleura nerve supply develops from plancopleuric layer of lateral plate mesoderm supplied by autonomic nerves. Autonomic nerves insensitive to pain supplied by sympathetic supply from T2 to T5 segment and parasympathetic, sympathetic and parasympathetic. Parasympathetic supply from vagus nerve. Blood supply and lymphatic drainage of the pleura. Parietal pleura, same as the thoracic wall, receives blood supply from intercostal, internal thoracic and musculophrenic arteries. Venous drainage goes in internal thoracic and azygos vein, and lymphatics drain into intercostal, intermammary, posterior mediastinal and diaphragmatic nodes. Now, blood supply and lymphatic drainage of the pleura. Visceral pleura receives blood from bronchial arteries and drains into the bronchial veins. Lymphatics go bronchopulmonary nodes. Bronchopulmonary nodes. Now, clinical integration. Now, pleural effusion, excessive accumulation of fluid in pleural cavity. Here. This is diaphragmatic. Normal costovertebral angle. See, this is normal angle. Now, this is your obliterated, this angle is obliterated. Angle due to pleural effusion. Radiograph normal and obliterated. Now, corresponds to costodiaphragmatic recess, lies between diaphragm and the chest wall, normally sharply pointed downwards and measures about 30 degrees. Accumulation of fluid in costodiaphragmatic recess, clinical integration, most dependent lower part of the pleural cavity, and pleural effusion tends to accumulate on this side. The dependent part, and that is having a recess. Costodiaphragmatic, the ribs and the diaphragm, that based on angle 30 degrees. Okay. Now, an obliteration of costodiaphragmatic angle in pleural effusion, chest radio shows obliteration of blunting or widening of costodiaphragmatic angle. See, this is increased. If this is sharp, normal, 30 degrees, this is widened up. Okay. Again, showing you in a enlarged, this is normal, this is obliterated. Now, clinical integration, referred pain of pleura, pain arising from parietal pleura, referred felt lower part of the neck and shoulder. This C3, C4, C5, referred pain. The phrenic nerve, the parietal pleura. Phrenic nerve root value C3, C5 and supplies parietal pleura. Small same nerve roots C3, C5 also supply neck and shoulder region. Supraclavicular nerves root value C3, C5. So if there is any pathology in the lung and then there is a referred pain, the site of referred pain, because they are from the same root values. Now, a cervical pleura projects above the clavicle root of the neck, may get injured in wounds, base of the neck. Injury cervical pleura may result in pneumothorax, accumulation of air in the pleural cavity. Atelectasis of the lung collapse, loss of negative intrapleural pressure, normally 4 millimeters mercury, results in lung collapse, atelectasis, due recoiling property of the lung. Now, pleuritis, and I told you earlier that pleural rub and inflammation of pleura. If you put a stethoscope, that is, you just expand your lung and you will see, you put a stethoscope, there will be a rub sound, and that is the pleuritis, the inflammation of the pleura. Okay. The sounds can be auscultated and called pleural rub. You have to have a stethoscope and then see. So when you go to your second year, you will be buying a stethoscope, you carrying it, but you use it. If you see a patient is gasping in the ward, immediately see, hear, what is the problem? Your simple tools, your stethoscope, your hammer, these two you must carry in your pocket. These two will give you 90% clinically the diagnosis. Pleural effusion, excessive accumulation of fluid in the pleural cavity, normal amount is 5 to 10 mm. Types of pleural effusion based on accumulated fluid. Pleural effusion is classified into the following types: hydrothorax, accumulation of serous transudate, hydrothorax. Now, pneumothorax, accumulation of blood, I told you. Now, empyema, pyothorax. Now, chylothorax, accumulation of chyle, hydropneumothorax, accumulation of fluid and air. Yeah. See, mid-axillary line, you put a aspirated fluid. See, pleural effusion, this is the pleural effusion. This is the thoracic cage, the ribs, 8th rib and 10th rib. In this between this is. So you go to most dependent part, this part, most dependent part, yeah. Okay. Now this is the repetition. These sketches you draw today, only draw these sketches. Your first thing when you go to the hostel, I told you after 10, before physiology, biochemistry you finish. And after 10 dinner, you will be sleeping like this. You read biochemistry, physiology, and you are reading anatomy in your guest house or Raj Nibas guest house. There is some Raj Nibas, Raja. Doctor Raja chance nahi. Rajas didn't, they made medical colleges in their grandfather's name and this thing. But they never studied, any Raja, I think that didn't study medicine. Because it is one of the most unpredictable and most tough. Your computer science, AI, all this has a limitation. Data analysis and all these things. Engineering. One bridge falls down. You see in your newspaper or your mobile that bridge collapses in Gujarat, bridge collapses in Bengal. So, no one is to be blamed. Okay, but one patient dies, you will be given a big shot. But one thing, a doctor should be a big actor. You have to be a good actor. And your expression, your activity, you have to prove it on the spot. You see, a patient comes, emergency ঢুকছে, but you have to show your efficiency. You just, who's the guardian? না আমরা সবাই, the পাড়ার লোক, no পাড়া, আমার ভাই. Okay, then let these people stay. Let these people stay there. দাদা আপনি গার্জেনের সঙ্গে কথা বলতে হবে তো, সই সাবুত আছে, yes, এইরকম স্পিডে কথা বলতে হবে. You have to sign and papers and documents. Anyway, patient's condition is to be used, and here you might need a blood, you might need some medicines or something, and you put a saline, and at least then you order, if it is a portable x-ray, if it's a RTA, road traffic accident, you order for a portable x-ray. The things come, machine holo, saline to aage chaliye dile, একটা হাতে তারপরে দুটো হাতে স্যালাইন চালিয়ে দেবে আর অক্সিজেনটা দিয়ে দেবে, তাহলে ওরা বলতো না ঠিক আছে, যে তারপরে দেখুন এটা খুব ইয়ে আছে, আপনার এখন 2 বোতল ব্লাড লাগবে, দেন একটা প্লেট দিয়ে দিল তোকে, সেখানে একটা কালেকশন আছে হিমোথোরাক্স। তারপরে তুমি ক্লিনিক্যালি দেখলে fracture, the rib fracture, one small particle or it is broken, that broken part might be having friction with the lungs. So that drains the blood into this. Now, these are the things you have to do it. Until and unless you know the your recesses, but this is in the mid-axillary line, the costodiaphragmatic recess is a very, very important. Everything is important. These are the things that referred pain, because even when you read abdomen, then gallbladder, if there is a pain, inflammation of the cholecystitis, acute cholecystitis, the patient may complain a pain in the tip of the scapula, angle of the scapula. Okay. Now, so that's a referred pain. Now, pleural effusion I told you. Now, causes: tuberculosis, congestive heart failure, cirrhosis of liver, infection, and so on. Now, thoracocentesis, aspiration of excess fluid from pleural cavity, treatment of underlying cause. Now, procedure under aseptic condition, cannula pass through the lower part of the 8th or 9th intercostal space in the mid-axillary line. Reasons: to avoid injury, neurovascular bundle lies in the subcostal group along inferior border of the rib, and avoid injury to the lungs that reaches up to 8th rib in mid-axillary line. So, below this part, the lung is not there, lung is here. Okay? Procedure: sitting upright, leaning forward on table. Now, there are some tables in the ward that you put like this and put the syringe, needle in the 8th intercostal space. Okay. Now, pneumothorax is a major complication of this procedure, so you have to take care. Also called pleural tap or paracentesis, involves the aspiration of excess fluid from pleural cavity. Pneumothorax, air entering through the pleural cavity through injured chest wall and pleura. Yeah. Flaps of injured tissue prevents exit of entered air. Pneumothorax, with a collapsed right lung. And the air puts the pressure, the lung collapses. Okay. Pneumothorax, accumulation of air in the pleural cavity is called pneumothorax. Normally, intrapleural pressure is always negative. Because of pneumothorax, this pressure becomes positive and causes collapse of the lung atelectasis. Shifting of mediastinal content to the opposite side, this goes this side, and causes injury thoracic wall and pleura, spontaneous rupture of pulmonary bulla. Now, there are some bulla like this. Bulla. It is a covering which, like you say, you take a balloon. Sometimes what we do, you just twist, you blow and twist, and you get it like this. Now, that is some disease condition, so the bulla is there. And tension pneumothorax. Surgical emergencies occurs Pneumothorax surgical emergency. Now occurs when air can enter in the pleural space but cannot escape. Occurs due to valvular air passage, one-way entry of air. This part. Signs and causes collapse of lungs and impairment of respiration, hyperexpansion of chest and deviation of the trachea opposite side. Now the trachea mediastinal shift is there and naturally one lung is functioning. It's been pushed and collapsed. So he will be in dyspnea. Like this. Dyspnea. Acute dyspnea. Now that's a surgical emergency. Tension pneumothorax treatment, surgical emergency. Thoracostomy involves insertion of needles in second intercostal space in the mid-clavicular line. Some interesting facts: pleural sac crosses thoracic cavity at following sites. Cervical pleura extends into the root of the neck at right costovertebral angle, at right left costovertebral angle. Mesoesophagus, both mediastinal pleura, right and left are opposition each other. They form mesoesophagus, similar to the mesentery, does not encircle the esophagus.